Bismillah ar-Rahman ar-Rahim. In the name of Allah, the most gracious, the most merciful, and peace on Prophet Muhammad sallallahu alaihi wasallam. Again, here I am back. I am back after 2 years of interruption and of not attending the Dentistry Online Scientific Days. Now we reached the 11th season. Actually, I passed the 9th and 10th seasons without attending. My last season was the eighth one. Unfortunately, I couldn't join last 2 years for personal reasons. Welcome for myself first again for being here, and much thanks and appreciations to my professors and elder brother, Dr. Mazen Domani, for inviting me again. The season this year becomes in a sadness of us on the events in our beloved Gaza Strip in Palestine, and also the recent updates in Syria, the new interruptions, and all the Arab nations are not in a well condition. What we can do, we can continue the boycott of these products of their products, and we can make those for them. Ask Allah to rescue them, and any type of financial support we have to proceed for too. This what in our hands once we are not inviting to join the Arab armies, so it's what only in our hands. And also, I would like to thank my beloved wife. She is an endodontist. Usually, she's providing me with the materials and references from which I can prepare my lecture before I start. And actually, she shortlisted my time, and she made the mission for me easy. Let's start directly today. Despite I'm an oral surgeon, but all of us are working in cosmetics, and also I taught multiple courses in conservative dentistry and in fixed orthodontics out of my specialty. So I will talk about the aesthetic alternatives for tooth restoration. Actually, I will not say something which is new or which is not known for the dentist, but rather I will rather talk about things which most of dentists know, but I will summarize and collect them in a simple light presentation. So let's go for the aesthetic alternatives for teeth restorations. And what are these alternatives? Actually, we have the veneers, laminates, lumineers, we have the modern composites, fiber posts, implants, orthodontic aligners, abrasive techniques, tooth bleaching, inlays, onlays, and the crowns. Let's go directly without telling an introduction that from long time we are saying commercially to our patients that we're going to do for you a Hollywood smile, which is not the scientific name at all. It's commercial trading advertising name that I will convert your teeth to be like the stars of Hollywood. So we are talking about veneers, laminates, and lumineers. And veneers are a broad name which include all these subtitles. Okay, first, when we know the veneers, we know the composite veneering when we were removing a very little layer of the tooth enamel to reshape the tooth or to correct the tooth discoloration or to correct the shape tooth part. Then it was converted directly to do a very little minute fine lenses which cover the labial surface and parts of the proximal surfaces, which were made of porcelain and composites. And we went for the laminates. Laminates are thinner than the traditional veneers. When it were known as a laminate, we want very specifically to a thinner layer. Again, it was made of porcelain and ceramics, whereas where are the broad name veneer, the title veneer also included the composites, but when we went specifically for the laminates, it was not fabricated from the composites, and the laminates have a different thicknesses and shapes which are customizable, and we can send them to the lab. Whereas the lumineers are very thin lenses which are added to the tooth with minimal prep or no prep, maybe not including an enamel preparation or including a very little enamel preparation. Okay, and the laminates have a very film thickness or a very layer thickness, which is very limited, which may reach to 0.2 millimeter. If you divide the 1 millimeter to 5 halves or to 5 parts, one of these parts will be your lumineer. But the laminates, the thickness may reach up to 0.5 millimeters, which is a thicker layer. So the lumineers are ultra thin, like your contact lenses, which you are wearing in your eyes, and it requires a minimal tooth structure alteration. Actually, the lumineers, not including a tooth correction or correction of misaligned or fractured tooth, it's more or less something which is cosmetic, make mask the discoloration and give a white shiny appearance to the teeth. But please don't do lumineers which you are seeing in the actors, like pieces of chocolates or piece of chiclets gum. Okay, please do something which follow the proper occlusion and follow the proper elevation, and please don't do a very wide lumineers for patient which appear totally artificial. Please select, be a doctor, be a dentist, select a proper shade which suits the patient and which match his face color, which match his smile line. Don't do a blocks of teeth very white which look ugly until this is a Hollywood smile. This is, sorry, it's not a smile, it's an ugly smile. These are the laminates and lumineers again. With improvement of the bonding techniques and technologies, and with the appearance of a recent technology in the bonding of the lumineers and laminates became an easy mission if you follow the proper guidelines, and the advancement in materials and the appearance of cements with different shades, which doesn't affect the translucency of the lens. It became a good cosmetic option to do laminates or lumineers, and also materials which mimics the tooth enamel. And now they are trying to see the hydroxyapatite crystals, what the composition, and try to fabricate in the lab lumineers which mimics the hydroxyapatite crystals formation. These are recent advancements. What about the composites? All of us are using composites daily. But please don't go to market and tell him, please give me composite. You have to know the physical properties of the composite and what are the particle sizes and where you use the composite and what is the shade of the composite for each layer of the tooth. Nothing is called that I will put a composite A1 for a central incisors. This is not applicable actually. Each layer of the tooth, the cervical, the middle, the incisal thirds have a different shades. Please select a composite which match the shade of the area to which you are restoring in the tooth. Please use an enamel composite. Don't do a layer of dentin composite on the enamel. Please keep the translucency of the enamel and appearance of the mamelons under or inside the dentine to give a natural locking of your composites. Before, very old, we were using the macrofilm, a microfilm, and the hybrid composite. Now the macrofilm became obsolete particles of composite sizes. We are now using the nano, hybrid, and microfilm particles of composites, which combine the polishability, the good physical properties together. And now the impregnation of recent particles of porcelain and zirconia inside the composites improve their physical properties. Please, please, please don't do total etch for your dentine. Please keep your dentine vital. Don't remove the smear layer. Please dissolve the smear layer and please use the seventh generation, which have all-in-one bonding agents, which only dissolve the smear layer in dentine with total etching of enamel to increase the surface tension and totally remove the smear layer from enamel. But please only dissolve the smear layer of dentine. Don't convert dentinal tubules to an open tubules with fluid movement and the patient complaining of hypersensitivity from cold after adaptation of composites. And with this experience, some doctors are telling to the patient, you will adapt to this composite because it's a new restoration, because he did a total etching of dentine. And by time, the bulb will be converted to a necrotic bulb under the composites with a little science and knowledge of dentist. And I think it's a medical mistake. It's malpractice to do a total etching of dentine. Please use the selective etching. Recently, they developed a new technologies in the composites. They fabricated a bioactive composite which can release calcium and phosphate. And also, the recent technologies made the composite can be adaptable with the change of the pH of the mouth. It can differentiate between acidity and alkalinity of the mouth. And also, the recent technologies in the fibers and in the fabrication of the particles made the composite very resistant to staining and to abrasion. Also, the updating in techniques before we were using the incremental layer to minimize the polymerization shrinkage and the buccal application of the light. And now the recent technologies involved application of or the use of bulk filled composites in which we can put a composite in a uni layer in which the light on different types of light cure modes can penetrate. And my word to the fresh graduates, please know the wavelength of the light cure which you will purchase from the market. Don't go and tell him, give me light cure and tell me the prices. You have to know the moods. You have to know the light. And please, please keep in each clinic a tester for the efficiency of the light cure to know if the light cure is still emitting the same light and change the lamp whenever needed. Don't use light cure for all over your life. Once it emits blue light, that okay, I'm using this light cure, it's working. Meanwhile, maybe the light penetration power decreased and you are still using the light cure. By time, it will become very weak and the inner layers of composite will not be cured and it will fail. Also, I think this is a malpractice. The using of digital shade guides also help to know the different shades of different layers of the tooth, cervical, middle, incisal, enamel, and the advantage of the good of the digital sheet guides like Vitamac and other generations of the digital devices made the problems of normal sheet guide, the selection of the color on light and darkness, the wettability of the tooth, or the tooth is dry. We were taking before when we were students that you have to measure the tooth shade in first day of June in middle of United States at 10 a.m. like this. This is this was the ideal situation. Meanwhile, now the digital solutions for selecting the shades of the different layers of the tooth made the story very easy and made you very professional to know each layer's color and to do a professional composite. Also, the use of fiber posts and implants. The fiber posts are now became an old technology, not a new. It was made of carbon or fiberglass. Okay, the good advantage of the fiber post that it's very light in weight, it's very aesthetic, and it's compatible with the core material like composite, and also compatible with the resin cements, which is cement them to the tooth. Before we were using the biometric posts, which are screwed. They were made from metal and they were screwed to the tooth and cause vertical root fracture. Now the fiber posts are available and very easy. It comes with the drill size, which mimic the post size, and you can measure them very easy. It comes very clear in the radiograph, and now their use become very familiar by most of dentists, and they carry a superior flexural strength, also reduces the chance of root fracture and the chance of transmitting forces to the walls of the root. And the use of glass implant also became an aesthetic solution. They are bioactive and they enhance the osseointegration. They are very good aesthetic solution when we are using them in anterior teeth. Actually, I didn't use, let me to be honest, I didn't use glass implants, or I didn't see clinically the glass implants, just I read about it. Maybe some researchers in our symposium will provide me with better information about the glass implants. Only I read about them, but I didn't see them clinically. The recent advancements in the posts, that now there are posts which are customizable, prefabricated. Prefabricated, no, we know only it's ready-made sizes. Now you can customize and adjust to the tooth tone. There is no excuse to use these old biometric screwed posts which cause failure and root fracture. Also, the surface treatment technologies improving the surface tension and woodability of the enamel and improving the bonding to the enamel and dentine. The made the post cementation to the tooth is an easy mission. What about the orthodontic aligners? Also, they are a good alternatives when you have mild cases of malocclusion. Now they are being fabricated by the 3D CAD/CAM softwares. What are the aligners? They are types of multiple series of invisible or of transparent removable orthodontic appliances, which are fabricated by a computer software. Meanwhile, you are taking a digital impression to the tooth, the computer can analyze the problem of malocclusion. Again, we are talking about mild or moderate cases, which doesn't include bone abnormalities. Okay, the aligners are now being controlled with the AI. AI give a predictable results, and the software, the computer software and mobile software. Now the patient can have a feedback on his mobile about the improvement in his treatment plan, and also the dentist can use the mobile application communicating with the lab who is fabricating the aligners, and the process can finish during the same day. The patient can take with him the first aligner. The computer will tell you about the aligners. For example, he will tell this patient will wear 12 aligners, and each aligners will take, first one will take 2 weeks, second one will take 3 weeks, until the malocclusion problem is corrected. Actually, it's a very good aesthetic alternative other than the orthodontic brackets. It's not a replacement to them, but it's aesthetic alternatives if the patient condition or the patient profession or the patient nature doesn't permit for him to wear an orthodontic appliances. So in these cases, the aligners will be a good options. The 3D printers made the process very easy. Again and again, the mobile softwares can control the process. And the use of abrasives. Abrasives, there are many types of abrasives. The macro abrasives, like the diamond burrs and discs, which we are using for recontouring in the case of reshaping or enameloplasty. In these cases, if we need to make a little correction. If the DSD told to you that this tooth need a very little correction, okay, you can do with the micro abrasive or with the discs. You can correct the angle of the tooth. You can correct the shape of the tooth enamel in some areas. If you want to fabricate a restoration for one tooth and you want the other tooth to look like, you can modify the other tooth's enamel with the macro abrasions, with the discs, and with the diamond pairs. Also, in the cases of enameloplasty in the posterior teeth, in the deep pits and fissures, in the case of susceptible pits and fissures, you can use, it's out of our topic of the aesthetic alternatives, but these diamonds again are used for this purpose. And the use of micro abrasives like the polishing base, which we are using in the tooth polishing after scaling, or tooth polishing for other purposes like for orthodontic bonding brackets, or for fabrication of restoration, and you want to show the natural color of the tooth, for photography issues, any purpose for tooth polishing, we are using a microparticles and the use of air abrasives. See the device on the right side. These air abrasives are now available, or are very old available. It's fitted on the four holes or two holes of the handpiece of the unit, and it emits an air. In this hole, you will put your polishing powder, and you will push the polishing powder by the pressure of the air, and they will start to polish the tooth. And also the digital solutions for air pressures, again, they are being controlled by the AI. The AI can tell you the amount of air that should be pushed and the amount of the powder that should be added. Okay, in this case, the powders and the amount of air make a very good result for the tooth polishing. Recently, the recent technologies and use of nano-diamond abrasive with high precision and nanotechnology made the story of macro and micro abrasives easier, okay, especially the macro abrasion, okay, by using of a very fine diamond particles which keep or which conserve the tooth enamel and help in the minimal invasive procedures. The bleaching, most of our patients dream to do bleaching because he think he will come one visit, the doctor will put a gel, my teeth will become whiter. It's adaptable in a very limited cases of discoloration where the extrinsic stains are easily to be removed, but difficult to be removed with the traditional scaling and polishing. We can use an in-office highly concentrated gel, and in a very little cases of intrinsic stains also we can use the high concentration gels. And now the recent technologies made the penetration of the gel to a deeper layer to bring the intrinsic stains from the tooth, made the process of tooth bleaching better and with a higher or a good results. So in office you can put your chemical gel with gingival protection, or you can adapt this zoom ultraviolet rays or oxygen plasma, whatever, okay, to the gel to be activated in 2 or 3 sessions. But the problem actually in this procedure that it causes a post-operative hypersensitivity, and it requires 2 treatments. Sometimes we need strong analgesics after the visit. And the using of walking bleach. What's walking bleach? In the case of endodontically treated teeth, where the tooth become discolored because the doctor did not remove the remnants of gutta percha, the tooth becomes discolored. Simply, you will open an access from the lingual side of the tooth, especially in the anterior, upper anterior teeth, and you will remove the excess gutta percha and defective restorations, and you will put your gel inside and close with a temporary restoration like the glass enamel or light cure temporary filling, and ask the patient to walk to home. So that it was called a walking bleach because the patient will walk to home, and then you will again check his shade please also use the digital shade guide to record on the computer the proper shade. Okay, and you will compare if the patient will need another visit or no. And at home, you give the patient a custom-made trays and low concentrated gel he will use at home, but with a very little selected types of patients and in a very limited conditions you can use at home bleaching. Recently, the light emission diode assisting the bleaching, the using of light other than the laser and ultraviolets made the process more successful and made the complications and sensitivity less. The use of peroxide-free whitening agents, which reduces the tooth sensitivity. Also, again, it's available commercially and it's very good in results like the PEP. And the using of nanotechnology again and again, nanotechnology in our work, the nanotechnology wipers fabricated, they have a very good results in whitening. And our last options are the inlays, onlays, overlays, and crown. What is the inlay? Inlay is a ready-made, or sorry, the custom-made, custom fabricated restorations which are adapted inside the tooth after you took impression and fabricated with your CAD CAM. Custom-made restoration is cemented to your tooth inside the tooth, but it doesn't cover the cusps. In this case, it's called inlay. If it covers the cusps, it's called onlay, and if it covers the totally the cusp and part of the outer surfaces, it's called overlay. But meanwhile, if it covers all the tooth, it's called a crown. From what it's fabricated? It's fabricated from composites, sorry, from porcelains and zirconium. Before it was fabricated from lab fabricated composites, but now we are using the CAD CAM in fabricating the zirconia and porcelain. When the porcelain was first introduced, we had the feldspathic porcelain or the traditional porcelain like Vitamark II IPS design. Then we had the lucitide reinforced glass ceramics like the IPS Empress, which were fabricated by Evoclar or Vivident. Okay, then the third generation with the lithium disilicate glass ceramics like the IBS, Emax, Press, MaxCAD. Also, it's fabricated by Evoclar Vivident. And then the alumina paste ceramics like the Procera, the Noble Procure, or the Noble Procure, sorry, this alumina paste porcelains, now they are being used. And recently we have the zirconia reinforced glass ceramics. Now they are impregnated the zirconia to the porcelain like the Celtra Dew and the fused composites. And also in the zirconia, we have many generations. First, we had 3% yttria stabilized TZP, and then 4%, 5%, okay, and multi-layer zirconia like Katana zirconia from Curari. These generations of zirconia are usually improved, started from the monolithic zirconium crowns. Well, these zirconium crowns provide a good strength and natural appearance, but again, there is dilemma about using it in the long span. Usually, we try to limit the zirconium used for the short span, okay, and the digital workflow, the using of the digital technology improve the issue. Conclusively, I would like to tell that selection of the material is very important. Okay, first select the technique you will use. Don't go behind the patient. The patient will tell you, I want veneer. Don't go for veneer. Tell him the available options and try to be conservative as much as you can. If you can do without tooth preparation, if you can do without causing a post-operative sensitivity, please follow that. Don't go for invasive unless there is no other options. And again, please Don't do total etching for dentine. Don't go to the lab and tell him make for me a porcelain crown. Please ask which type of porcelain you are using, which generation, which type are the types we mentioned, and read about the advantage and disadvantage of each type. It's not a shame for you to read in front of the lab technician about the advantage of this type, especially if he tell you about a commercial type. Read about it, about its physical properties. Don't go for prices. We are not a salesman. We are doctors and a dentist. Allah subhanahu give us the knowledge to differentiate between different types. Also for the zirconium, I saw before a zirconium lab. He made a zirconium like a plastic, which is broken down like an acrylic. Okay, please see which type of zirconia. Don't go for the cheaper lab. Go for the lab who is using a recent technologies and who is using a good materials for fabrication. Actually, it was my little presentation today, and it was my honor to be with you in this Dentistry Online Scientific Days in its 11 seasons. My regards to my Professor Dr. Mazri Domani, to Professor Dr. Adnan Habib, and to all my colleagues who will be contributing to this event. And in the last, I send my prayers to our brothers and sisters in Gaza. May Allah secure them. And inshallah, when we come next year for the 12th season, Gaza will be in a better condition and will be repelled. And inshallah, all people will be in their houses. And may Allah give mercy to our brothers and sisters who are sacrificing themselves, and inshallah they are shuhada عند ربهم يرزقون. السلام عليكم ورحمة الله وبركاته.